Coronary artery disease is typically viewed as a strictly cumulative process. Plaque builds up, arterial walls harden, and blood flow narrows over time. Because of this tendency toward accumulation, standard clinical care is almost entirely focused on slowing the rate of disease advancement rather than attempting to eliminate it. But there is a higher clinical target in cardiovascular medicine: structural regression. Structural regression is the measurable physical reversal of the disease. It describes a state where existing arterial blockages are forced to shrink. To prove that actual biological reversal is possible, we must look past standard clinical assumptions and examine undeniable visual evidence of an artery clearing itself out. This is Peter Megdal. Between 2014 and 2018, his cardiovascular system underwent a 4-year physiological shift that challenges conventional medical expectations. The evidence for this shift is captured in the Megdal serial angiogram, a side-by-side comparison of his coronary anatomy taken 48 months apart. The data shows that over those 4 years, severe, highly vulnerable arterial plaques inside his heart were systematically dismantled. When presented with images showing significant arterial widening, the immediate question is one of validity. We have to determine if this is genuine biological healing or simply a discrepancy in how the cameras were calibrated between the two studies. To accept this data, we must relentlessly audit the exact measurement methodology used to capture it. Comparing two vascular images taken 4 years apart introduces technological variables. Differences in camera angles, detector geometry, and pixel distortion can create the illusion of changes in vessel width. To eliminate these errors, the study utilized quantitative coronary angiography, or QCA. QCA is the objective medical standard for measuring the exact inner dimensions of coronary arteries. To ensure accuracy, QCA requires a strict calibration step. By identifying the catheter tube in the image, which has a known physical size, the software performs a pixel to millimeter conversion. This provides an absolute measurement of the vessel's diameter. In this case, the exact same imaging machine was used for both the 2014 and 2018 scans. Because the identical calibration grid locked over both studies, errors from different image processing algorithms were eliminated. The analysis then utilized standardized red tick marks to establish identical length segments on both images. This ensures an exact apples-to-apples spatial comparison across the 4-year interval. With the spatial calibration mathematically locked, any geometric widening observed in the vessel walls represents a genuine biological change, not a digital artifact. With the methodology verified, we can examine the specific findings, starting with a location known as the first diagonal branch origin. In 2014, this branch exhibited severe stenosis, with a diameter reduction of 60 to 75%. This indicates a high-grade blockage restricting blood flow to the heart muscle. In the 2018 follow-up, the exact same segment is fully patent, meaning it is wide open with less than 10% blockage. This represents a 65 percentage point reversal. Physically, a 65-point reduction means a high-grade obstruction has been almost entirely cleared from the artery. Plaques capable of this degree of reversal are typically lipid-rich and highly inflammatory. Densely calcified or fibrotic lesions are much more rigid and less likely to shrink. Documenting this level of focal clearance forces a re-evaluation of the physical limits of arterial recovery. Such a dramatic clearing at a single branch raises a skeptical question. Was this specific reversal the result of a surgical intervention, such as a stent? Mechanical interventions cause highly localized widening at a single point, but they leave the rest of the surrounding arterial tissue in its diseased state. To determine the cause, we have to look at the wider data across the standardized segments of the left anterior descending and circumflex arteries. The data shows that the vessel widening is generalized across all segments. The average lumen diameter, the mean width of the entire vessel, increased uniformly along the length of these major branches. This uniform expansion is a sign of healthy positive remodeling. Furthermore, the lack of abnormal expansion rules out pathological dilations, such as coronary artery ectasia. Because the healing is systemic and diffuse, it proves a systemic metabolic shift occurred, ruling out localized mechanical surgery as the cause. This widespread structural improvement leads to a core biomechanical question: how does a physical atherosclerotic plaque actually shrink and exit the body? The process is governed by the metabolic ledger of the arterial wall. specifically the net reduction in percent atheroma volume, or PAV. On the withdrawal side of this ledger, the body must increase the capacity for cholesterol efflux. Engorged foam cells actively eject their stored lipid particles, while the immune system clears out cell fragments from the plaque's necrotic core. On the deposit side of the ledger, the therapeutic environment must strictly limit the amount of new cholesterol being deposited back into the arterial wall. Plaque volume shrinks only when the rate of biological clearance sustainably outpaces the rate of new accumulation. Sustained biological reversal is a physiological state where cellular waste removal consistently outcompetes waste deposition over a period of years. Moving from microscopic mechanics to macroclinical outcomes, we have to establish what this volume reduction means for patient survival. Clinical research has established a direct link between plaque shrinkage and the odds of suffering major adverse cardiovascular events, or MACE, a category that includes heart attacks and strokes. The correlation is highly leveraged. A mere 1% reduction in percent atheroma volume results in a 20% reduction in the odds of a major event. This drop in risk occurs because shrinking the plaque's volume stabilizes its structure. By removing the inflammatory lipid core, the lesion is stripped of its tendency to suddenly rupture. The anatomical widening documented in the 2018 follow-up translates into a stabilized, low-risk cardiovascular profile. What specific intervention is powerful enough to maintain this net negative atheroma state for 4 years? The catalyst driving these changes is a protocol known as intensive lifestyle modification, or ILM. This protocol requires extreme rigor, a strictly whole foods, plant-based diet paired with moderate regular exercise and structured stress management techniques. The 2018 angiogram acts as an objective, unforgeable physical receipt, proving the patient's sustained compliance with this intensive regimen. The serial Megdal angiogram proves that given the right metabolic inputs, the human vascular system possesses an inherent capacity to dismantle its own disease and permanently alter its trajectory.